Good morning, everybody. Before I begin, I would like to thank the committee of MOCAT for inviting me and for their efforts for arranging this meeting. Today, I will talk about a sensitive topic in pediatric ophthalmology, which is the pediatric IOL implantation, when to implant, and what to implant. Everything is in this lecture. Why we choose this lecture? Because it is a unique challenge, the treatment goals, the key decision. All the slides in this lecture is either from AAO or the solid studies about infant FAK, the toddler FAK and pseudo FAK study, or the consensus of European or Royal College of Ophthalmology. We choose the most solid data for the IOL. So we will begin as a session roadmap. We will choose the age and go by, in each age what to do, whether to keep the patient aphakic or to implant an IOL. So to begin with, from 0 to 6 months, we routinely recommend to keep the patient aphakic without implanting an IOL, because there is primary IOL show no visual acuity advantage in this age, and all the recommendation from studies to keep the patient aphakic in the first 6 months. From 7 months to 24 months to 2 years, the recommendation also to keep the patient aphakic. This is called the gray zone. We can strictly keep the patient aphakic. We have strict criteria for implantation in this age group. Regarding the following age, from 2 to 5 years, we can implant primary IOL as a standard of care, because primary IOL is default standard. Biometry here in this age is more predictable. The axial length is slower than infancy, and safety profile is excellent. We continue to do posterior capsulorhexis in this age, and also anterior vitrectomy is mandatory to prevent posterior capsular opacity. And the monofocal is the gold standard. We'll talk later about what to implant. From 6 to 12 years, the primary IOL is a routine, because also we said the axial length is more stable, reduced variance in myopic shift compared to infant and toddlers. And it is crucial to discuss with the family that there is loss of accommodation, and parents must accept that their children will need a bifocal glasses for near. We will always put the patient on target refraction closer to emetropia in this age group. From 13 to 18, we will treat the children like an adult, like planning, with pediatric safeguards. Targeting is emetropia. We can add here toric IOL if there is significant astigmatism, but we should counsel the families about the dysphotopsia risks, glare halos, which can be bothersome in young active patients with larger pupils. This is the timing for unilateral versus bilateral timing and strategies. This is algorithm for the first 5 years. As we said, below 6 months, we strictly advised for FAK and glasses correction. Above 2 years, primary monofocal IOL is the standard of care, gold standards. Between them, from 7 to 24 months is the gray zone. We keep the patient FAK, and we have strict indication for IOL implantation. Regarding the patient FAK, we have a new technology called the ultra-thin high-index glasses in FAK children. This ultra-thin is half the thickness, maybe 60% reduction in the thickness of the glasses. Also in the weight, half of the weight, flatter, less magnification, less distortion, minimized. يعني مو مثل هاي اللي كانوا يسموها كعب استكان، تكون كلش thin, minimize the distortion and high comfort. This is in comparison. You see the traditional high plus lenses and the ultra-thin high-index lenses. 60% decrease in thinner edges and 50% in weight. So this child, yes, he's fighting for his glasses. Regarding the second part, standard monofocal IOL is the gold standards when we choose to implant. The best option here is the standard monofocal IOL. because there is long-term evidence based in the infant FAK and the toddler FAK and pseudo-FAK studies. Regarding the enhanced monofocal IOLs, like for example, the IHANS. The IHANS, we have a similar distance vision, but significant gain in intermediate vision. This is crucial for parent counseling. These are not a reading glass. You should counsel the family that their children will need bifocal, but with a lesser degree than the usual standard monofocal. Regarding the EDOF IOLs, very limited pediatric evidence, still data limited to case report and small non-randomized series. A major concern who risk of reduced contrast sensitivity critical for developing visual systems in pediatric age group. So it is not routinely recommended. Regarding the multifocal IOL, it is also not a standard of care, highly selected only, and special age group mostly above 12 years. So the strict inclusion criteria for a premium IOL, older adolescents only above 12 years, perfect biometric stability, zero ocular comorbidity, and extensive pre-op counseling. And as we discussed, the standard monofocal remain the gold standard for more than 95% of pediatric cases due to reliability, clarity, and ease of future management. This is the pros and cons of each IOL, the standard monofocal, the enhanced monofocal, and the EDOF, and the multifocal also. A study about the visual axis opacification, the primary challenge in pediatric cataract surgery. We see here that whenever we implant a primary IOL, there is increase. Like in unilateral cases, within 1 to 6 months with the primary IOL, there is high visual axis opacity, maybe 70% by 5 years. Also in bilateral cases, while the patient FAK is 80% of visual opacity axis.
You have 1 minute.
Okay. Also, the glaucoma risk remains the most common vision-threatening complication after cataract surgery. We should do a lifelong monitoring is required for glaucoma. Reoperation, study about reoperation. Also, the reoperation risk in infants increase with the primary IOL implantation. Okay, I would like to thank you.
Thank you very much, Dr. Mohammed.